Well, hello everyone, and welcome to our first All Things Celiac webinar of 2026. This series is brought to you by the National Celiac Association and the Harvard Medical School's Celiac Education and Research Program. Today, we are uncovering the base of the celiac iceberg, from case finding to universal screening. My name is Chris Rich, and I am the CEO and Executive Director of the National Celiac Association. At NCA, we provide educational resources to our celiac community, such as this All Things Celiac webinar series, and we value the opportunity to continue this work in collaboration with the Harvard Medical School's Celiac Education and Research Program. In addition to our educational programs, the National Celiac Association offers an extensive support network that reaches from coast to coast and assists everyone from kids and their families to our celiac seniors. We are also helping those individuals in our community who face food insecurity using our Feeding Gluten-Free program, which works to provide gluten-free food directly to food pantries nationwide. You can find more information about the ways that we act as the voice of our community on our website at nationalceliac.org. The highly collaborative Harvard Medical School Celiac Education and Research Program was founded in 2013 and has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. Education is at the heart of the HMS Celiac Education and Research Program, and these webinars continue to feature multidisciplinary speakers with specialized knowledge on celiac disease, related autoimmune conditions, and nutrition. Today's session is being recorded and will be available for viewing on the National Celiac Association's website at nationalceliac.org. On our site, you can select the Resources tab from the drop-down header and click on NCA Webinars. From there, a tab will link you to the All Things Celiac webinar series. The recording of today's session will appear there in approximately 5 to 7 business days. Our moderator for today is Dr. Denis Chang. Dr. Chang is a pediatric gastroenterologist at Boston Children's Hospital, specializing in the care of children with congenital and acquired esophageal disorders within the Esophageal and Airway Treatment Center, as well as gluten-related disorders within the Celiac Disease Program. He is also a member and co-vice chair of the Celiac Disease Special Interest Group within the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. His clinical and research interests include evaluating the accuracy of diagnostic tests for celiac diagnosis, as well as outcomes of children with potential celiac disease. So without further hesitation, Dr. Chang, the floor is yours.
Thank you so much, Chris, and thank you so much to the National Celiac Association for hosting these very educational webinar series. It's always a joy to be a part of it, and I'm really excited to introduce our first speaker for today's talk. But before then, I just wanted to explain a couple of ground rules, one of which is the Q&A option. There will be a Q&A format where following the two speakers and during the whole presentation, any of our viewers are able to submit general relevant questions to today's topic. And we'll do our best to get through as many as we can. We also have several different questions that came in prior to today's webinar. So hopefully we'll be able to cover many of your inquiries. In addition, Chris, are you able to just do the next slide? There are continuing educational units available for today's presentation. The system is going to be a little bit different from past webinars, and so you are going to need to create a CEEI account if you haven't done so already from the past webinar. And this information is going to be shared through the chat function so that people can sign up if you haven't. And then you just need to text this code to this number using the number that you registered with in order to claim CEUs. And it's available for registered dietitians, nurses, as well as physicians and social workers. Without further ado, I wanted to introduce our first speaker, Dr. Carlo Catassi. If Dr. Catassi, you'd like to share your slides. Dr. Catassi is internationally recognized for his groundbreaking work on celiac disease epidemiology, screening, clinical manifestations, and diagnosis. He is a prolific researcher with more than 270 publications in the medical literature, a majority of which are on celiac disease and other gluten-related disorders. Dr. Catassi is a full professor of pediatrics at the Polytechnic University of Marche, Ancona, Italy, and a member of the Scientific Advisory Board for Pediatric Screening of Celiac Disease and Type 1 Diabetes at the Italian Institute of Health in Rome, Italy. His lifetime research activity has been focused on the epidemiology of celiac disease, which he studied in Europe, North and South America, and Africa. More recently, his major interest is focused on the design and evaluation of pediatric screening programs for celiac disease. Without further ado, Dr. Catassi.
Thanks, Dennis. Ladies and gentlemen, good afternoon. I'm really honored to give this presentation to the Harvard Education and Research Program on celiac disease. I will now share my slides. Yes, I will mostly tell you something about this program on screening for celiac disease in Italy. And these are my disclosures. Yes, the new era of the epidemiology of celiac disease started several decades ago when we had available very specific and sensitive and simple tests to do for the diagnosis of celiac disease. Initially, it was the anti-gliadin antibody, then the anti-endomysial test, and more recently, the anti-transglutaminase and many others. So the availability of this test allowed to investigate very in depth the epidemiology of celiac disease. You may ask why today we have a program of screening, of mass screening for celiac disease in Italy. And I think the first reason is that the interest on the epidemiology of celiac disease in Italy has always been present for several decades. And more than 30 years ago, basically, we published one of the first papers on the prevalence of celiac disease in the general population as investigated by the serological tests. At that time, we had only the anti-gliadin antibody, but this was already a quite good test. Then we had more specific and sensitive ones, but at that time we could already give some very new information because in the past, celiac disease was considered a very, very rare disorder, and mostly affecting people of European origin with blonde hair and blue eyes. This history was not true at all. In that study I showed you before, we found that the prevalence in the general population of cases that had been diagnosed by the doctors was something like 1 every 1,000 children, as you can see here. But performing the serological test for celiac disease, at that time, the anti-gliadin antibody, we could find at the end that the overall prevalence was 10 times more high. And you see, we found a prevalence in school-age children close to 1% of the general population. These data were presented at meetings in several opportunities and were also replicated in many, many countries. For example, in the United States, Professor Fasano, at the beginning of the 2000s, he published a very important paper showing that the prevalence of celiac disease in the United States is quite similar to the one we found in Europe. So, to make a very long story short, I will show you now the results of our more recent study on the prevalence and epidemiology of celiac disease in Italy. This was a multi-center study that has been published a few years ago. In this study, we used a different algorithm. We went into the school and to perform a finger prick, a single drop of whole blood to test for the HLA antigens predisposing to celiac disease, HLA DQ2 and DQ8. This means that we found something like 40% of the screened subjects that were positive, and therefore we were able to select an at-risk group of children that were recalled in the clinic to make the test for the anti-transglutaminase on whole blood. So this was the first step of the screening, DQ2 and DQ8 in the school. Those who were negative, of course, stopped the protocol here. Those who were positive went into clinic to perform total IgA and serum transglutaminase of IgA class. At the same time, we also checked in these children if there were criteria for the case finding. What does case finding means? Means checking for celiac disease in those who have at-risk factors for this disease. And there are so many. For example, family history of celiac disease, persistent intestinal complaints, iron deficient, and so forth. So we were able to see how many of these recalled children presented one or more of these criteria. So the protocol went on in those who were positive for the TTG. We recalled them to perform the anti-endomysial test, and eventually some of them went to the small intestinal biopsy when the title of the TTG was low. For the others, according to the HESPGAM protocol, the protocol of the European Society for Pediatric Gastroenterology, we didn't need to perform the biopsy to make the diagnosis of celiac disease. Therefore, we had a very clear-cut picture in this sample of something like 10,000 children across Italy. Here you see the different centers that participated in this survey. The overall prevalence in this sample of school children was 1.6%, which is a very high value. You can notice that there are differences in the different centers participating to this procedure, but they're really not big differences, and probably depending on the small size of the sample. But the impressive datum was this 1.6% prevalence. And if we compare this prevalence of almost 1.6% with the one we found 30 years before, you can see that the situation had completely changed. The overall prevalence has increased almost 100%. Nowadays, we are able to diagnose on clinical basis more cases, but still they are a minority. They were no more than 30%. So you have here an idea of what we call the celiac iceberg, which is the deep blue area in this picture. It is interesting to know that the increasing prevalence of celiac disease has been documented in several countries, not only in Italy, but also the US, in other European countries. And we really don't know the reason why the prevalence has increased. This is not the incidence which is increased because there is more awareness of disease, the tests are performed more easily, and therefore the number of cases that are diagnosed on clinical grounds has increased a lot. But this is the overall prevalence. And it is quite alarming to see that it has increased a lot in many different countries. But I would say that even more interesting for the talk I am giving today is the figure of the iceberg in this population sample that we investigated, because we were able to measure the visible part of the iceberg. These are the children who were diagnosed through what we call a passive case finding procedure, which means that the child has some symptoms, for example, abdominal pain. The mother brings him to the doctor, and the doctor prescribes the investigation to clarify the situation. Well, in this way, in a country that shows a very high awareness about celiac disease and the variable presentation of the disease, we were able to diagnose only 35% of cases by passive case finding. But looking to all the children that had some of the criteria I told you before about case finding for celiac disease, we noticed that further 38% in the sample we investigated could have been diagnosed by active case finding, which means testing all subjects who have at least one of these situations that I showed you before. But the situation was that almost 27% could be recognized and diagnosed only by mass screening. And therefore, here you see a good reason for the superiority of mass screening versus case finding, because even with the very well done case finding, you are not able to reach a significant proportion of cases that remain undiagnosed. Well, this situation was presented, of course, to the Ministry of Health. We discussed about it on the newspaper. We tried to give, importance to the results of the study. We didn't believe that someone could listen to us, but what happened when we say that also celiac disease fulfills the requirements for population screening? For example, it is a very important health problem. There may be a very long silent stage where the disease it's difficult to diagnose. We have a suitable test for diagnosis, for example, the anti-transglutaminase test. The test is accepted by the population, and there is, of course, an accepted treatment that is the gluten-free diet. So we gave these arguments to politicians, and what happened, I couldn't believe this, is that after a few months, there was a law on pediatric screening for celiac disease and type 1 diabetes. There was a strong push also by the type 1 diabetes community, I have to admit, but you see myself here as the lunatic on the grass. I couldn't believe that I was discussing about screening with the politicians here in the middle, but that was the reality. And we had a law that suggested to screen all children that are resident in Italy, of course, with the informed consent of the family. And the law also suggested to perform a pilot project during the year 2000, 2004, and 2024 and 2025, just to check the feasibility, the acceptance, the sustainability of the screening program. So we did this in 4 areas of the country in a limited study group. You see more than 5,000, just to check the feasibility of the project. We still do not have the final result of the study, but just to show you some preliminary data, you see that we have 2.8% of children that were positive at the first level screening test for celiac disease, and unfortunately also 0.2% of children who have at least 2 antibodies against type 1 diabetes, and this will most likely develop type 1 diabetes in a few years. We will see the final results of the study, but in the meantime, we are organizing the nationwide celiac disease screening program that will start in a few months. Of course, we are facing with a number of problems that I listed here. All of these aspects will influence the cost of the procedure, and this is, of course, is a very important issue to consider, because it is public money that need to be spent, and therefore it is not easy to do all what we want to do. But I want just to show you briefly some of the problems. For example, what age should we screen for celiac disease? If you want to catch more cases, I would say later in life, because we know that celiac disease might develop at any age. But if you want to maximize the efficiency of the screening, the earlier is the best. So we have to find a compromise. And what can be done is repeated testing. For example, let's say 5 years and then 10 years again. But in this case, it's very useful to select a sample, a subsample of the population. And this can be done testing at the first time for the DQ2 and DQ8, because if children do not have the DQ2 or DQ8, will never develop celiac disease. So we can exclude at least 60% of the pediatric population from further screening later in life. Another problem is what kind of test do we use? In the pilot project, we used capillary blood. It was not easy, I had to tell you, to take 200 microliter of blood to do all the antibodies. So I think we will shift to a different procedure. For example, we are working now on the DBP, on the dried blood spot, to test for both antibodies for type 1 diabetes and celiac disease. This is much easier to be done, to be shipped, but another possibility is to test the saliva for the antibodies. This is very interesting. And also the POC test that can be done directly at the first level. We have to choose the best possibility, and I guess at the end we will choose the dried blood spot, which allow you to measure on a quantitative basis the antibodies. So at the end, what did we suggest to the politician to do? This is what we call the Ferrari algorithm for pediatric screening for celiac disease. Is the best one, we would say. By screening for DQ2 and DQ8 at birth. This could be easily done together with many other neonatal screenings, and therefore in this way you can exclude almost 60% of children from further investigation for celiac disease. Those who are positive could be screened at 3 to 5 years with the antitransglutaminase test for celiac disease. If they are positive, of course, they go ahead with the protocol for the diagnosis. If they are not positive, we suggest to repeat the test after at least 5 years to check of a late seroconversion. And of course, if they develop symptoms at any age, they can perform the TTG test even before. There were objections to this protocol, mostly because it is quite expensive, but as Marisa and I and others suggested recently, it is a very good protocol not only for secondary prevention of celiac disease, but also could be for primary prevention, because if you select children who are at risk for celiac disease at birth, you can focus on this 40% of babies and who could be potential target for celiac disease primary prevention studies. For example, changing the nutrition, giving probiotics or other possible intervention. What we got and we knew really recently, it's something much simple. I would say the concept of the HLA screening did not convince the politician. You know, there are some resistance against genetic testing, so they allowed us to screen only for the transglutaminase IgA and IgG in 5 to 6 years of age. If they are negative, the screening is stopped, and if the screening is positive, of course, they are referred to pediatric GI centers. This is what I call the 500 car protocol, but I am not disappointed about this conclusion, because I think it's very important to start, because as soon as we start, we will check possible improvements of the algorithm. Different regions will screen with slightly different protocols. So we will have the time to investigate what is the best algorithm for the screening. But at the end, it's very important to start it. And now I'm able to tell you that during the next 3 to 4 months, most regions in Italy will start to screen children for celiac disease. And this is really a very important result, in my opinion. So to go to the conclusion of my short talk, it is quite clear that the long-standing knowledge of the epidemiology of celiac disease in Italy paved the way to the law on celiac disease mass screening. Our data show that the prevalence of celiac disease in Italy is currently higher than 1.5% in school-age children. And still, despite this high awareness of disease in my country, more than 50% of cases remain undiagnosed. Of course, what I didn't say, but we will have time to discuss it, undiagnosed celiac disease children are exposed to the risk of short and long-term complications. This is the most important reason to screen for celiac disease children. And as I told you, our data and the data of other groups showed that the mass screening is much superior to case finding for detecting undiagnosed celiac disease. And despite several open questions and a lot of discussions, we have we saw recent paper on the literature suggesting that the cost of the screening is too high. There could be more important problems in the public health to address instead than the celiac screening. But I'm really convinced that over the next few years, it will be clearly shown that celiac disease mass screening in children is a milestone in the pediatric preventive medicine. I'm sure that these are all the people that I have to thank for working with me on these projects. And as I said, I am quite sure that Marisa and the group of people that you see in this picture that we took in Denver quite recently, where we met to discuss the problems of the screening. These people will be able to show to the whole community that celiac disease screening it's a goodbye, let's say. And I thank you for your attention and here for possible questions. Thank you very much.
Thank you so much, Dr. Catassi. It was so nice to hear the story behind how this really breakthrough law has come into place for screening a relatively common condition that can really go under the radar for some time. And so hopefully we'll learn more from your country's experiences, your work, and perhaps other places across the globe will also adopt similar practices. Next, we have Dr. Marisa Stahl. Dr. Stahl is the Director of Research at the Colorado Center for Celiac Disease at Children's Hospital Colorado and an assistant professor at the University of Colorado School of Medicine. She's a board-certified pediatric gastroenterologist with a focus on celiac disease clinical care, gluten-related disorders, and other gastrointestinal conditions, and celiac disease screening research in both high-risk groups and the general population. She's a co-investigator in several studies, including the Autoimmunity Screening for Kids, or ASK study, a general population screening study for type 1 diabetes and celiac disease, the Environmental Determinants of Diabetes in the Young, also known as a TEDdy study, an observational study of children at genetic risk for type 1 diabetes and celiac disease, and the Human Trisome Project, a biobank for individuals with Down syndrome. Without any delay, Dr. Stahl.
Thank you so much to the organizers of this webinar for inviting me to speak, and Dennis for those very kind words. Dr. Catassi will be a very hard act to follow, but I'm going to try. Today, I will be speaking about screening strategies, programs, and implementation in the United States. And here are my disclosures, none of which are related to the talk I will be giving today. So in this talk, I'll start by reviewing screening strategies, or how screening is currently being conducted in the clinical and research settings in Europe and in the United States. And then we'll move on to discuss research programs here in the US. And then I'll finish off with just a couple of slides regarding screening implementation for the general population and what really needs to still be addressed for screening to happen here in the US in the future. So celiac disease prevalence and incidence is rising. It's important for our providers to have a low threshold to screen in the clinical setting for this very common autoimmune disease. And I'm sure many patients and family members listening into this talk likely have stories regarding their own diagnostic journey. What you can see on this slide is one meta-analysis on the incidence of celiac disease on the left-hand side. Shows that celiac disease incidence has really been rising over time. And you can see that all the included regions in this meta-analysis, including the US in bright green, on the y-axis, the incidence of celiac disease has been increasing over time, which is shown on the x-axis. And then shown on the right-hand side of this slide is the cumulative incidence of celiac disease over the first 15 years of life in the TEDdy study. And what you can see is that the cumulative incidence rises, particularly more rapidly early in life, and then this begins to plateau around age 10. And I think this is important when we're talking about celiac disease screening, because it really does make sense when we're talking about general population screening to focus our efforts in the pediatric population. So with celiac disease being so common and becoming even more common, the idea of screening has really come to the forefront. But the approach to who to screen can really vary. We can screen based on the presence of symptoms, as Dr. Catassi was talking about, either passive or active case finding. We can screen based on high-risk features, and this is known as targeted screening. Or we can screen the general population. And so let's talk about the current landscape of celiac disease testing. Clinically, we know that people with classic symptoms of malabsorption, like this child on the left, abdominal bloating, poor weight gain, diarrhea, should be tested. Ideally, individuals with non-classic symptoms, such as dermatitis herpetiformis, which is shown in the middle picture, a characteristic rash of celiac disease, should also be tested. But the problem is that there's also a lot of non-specific extraintestinal symptoms that may be associated with celiac disease, such as headaches, brain fog, and joint pains, where people may not be getting tested. And now, variably here in the US, individuals with a family history or other associated high-risk conditions are screened. And these individuals may have more subclinical, meaning that they have unrecognized symptoms that are recognized after they're diagnosed and treated, or completely asymptomatic presentations. But even this screening relies on healthcare providers to recognize these symptoms or conditions and then send the testing for celiac disease. So there are many individuals with classic and non-classic symptoms who are identified because of screening. And there are also many who are not picked up by our current algorithms. And so once again, to address this gap, the idea of screening has been emphasized. And there are broadly 3 different approaches to screening. And this Iceberg based on the title of this webinar, shows the prevalence that's kind of unearthed by these varying strategies. So the first is active case finding. And as Dr. Catassi was explaining, this is the testing of children who are actively found to have symptoms. And so this is different than what we are doing just in our, general GI clinics, because active case finding entails actively seeking out symptoms, for example, in a primary care clinic with a symptom checklist, at well child visits, and then you screen any children who endorse these symptoms. And this certainly helps us find more children underneath the so-called peak of this iceberg, but it still misses many children with subclinical or asymptomatic presentations. So that brings about targeted screening. And this is what is currently endorsed by our national GI organizations for screening for those in high-risk groups. And that's regardless of symptoms. And this certainly also helps increase identification, but a majority of children who have celiac disease will not necessarily have a family history or symptoms. So the only way to really identify all children with celiac disease is through general population screening, which we'll discuss the potential advantages and disadvantages of in this talk. And so this here is an example of active case finding. In the next couple of slides, I'm going to dive more into each of these strategies. And I'm using an example from the Netherlands. Once again, active case finding is the process of actively seeking out those who may have compatible symptoms for screening. And so Gluten Screen is a screening study in the Netherlands that uses active case finding to screen children with a curated symptom list at youth healthcare centers in the Netherlands. So it's ingrained in their primary care. And those who check off any symptoms get screened with a TTG IgA point of care test. And Dr. Catassi already went into some of the different types of testing that we can do for celiac disease. And this is the list of symptoms that they use to decide who should be screened for celiac disease. And I'll show you the data in terms of prevalence of kids diagnosed with celiac disease through this strategy. But I do want to point out that, while this certainly helps pick up more kids, when you think about it, it's not necessarily limiting the testing all that much, because I think if parents are overall being honest, if you look at these symptoms, having a 4-year-old myself, you're going to check off probably at least one of them for your child, regardless of whether or not they have celiac disease. I mean, asking parents of a 4 or 5-year-old, is your child regularly irritated? I think many would say yes to that question. But what you can see from the gluten screen study is that from this study, 1.7% of tested children were diagnosed with celiac disease. And the positive predictive value for the point of care test that they used for celiac disease was actually pretty good. It was 92%. And this really does make sense in the Netherlands, because ethically, using this strategy is more acceptable than a general population approach. And what you can see in the table here is that the incidence of detection was improved among all age groups with an active case finding approach compared to the standard of care. And so with that, I'm going to shift gears and talk about targeted screening. Once again, this is the screening of individuals known to be at higher risk of celiac disease, regardless of symptoms, including those who have a family history, those with other autoimmune diseases, and those with specific genetic syndromes. And this is what is currently recommended in the US as far as screening. On this slide, you can see that overall, RGI organizations support screening to some degree in at-risk populations. But I should emphasize that this is the guidance from our national GI organizations, and there is also variable guidance from other groups on more disease-specific recommendations. So our organization supports screening, but how often is this actually being done? So what studies show is that it's not being done as often as we would like. One study showed that overall, only 5.4% of those with high-risk conditions are getting screened. One study looking at family members showed that only approximately half were tested, and approximately 30% of those with associated symptoms or conditions were not tested. One study looking specifically at type 1 diabetes showed that only 35% of surveyed clinics screened diabetes patients for celiac disease. And specifically in Down syndrome, one study that looked at screening showed that those tested because of symptoms had symptoms for significantly longer. So I think all of this just shows that implementation of targeted screening in the US is an issue. And Dr. Catassi already showed this lovely checklist, but this is the World Health Organization criteria for a disease that should be considered for general population screening. And as Dr. Catassi showed, celiac disease really does meet many of these check marks. We know that it is common. We have good tests to screen for it. Overall, it's been shown in several studies to be acceptable, although I think there is more work needed in this area. It is effectively treated with a gluten-free diet, and I've shown you that clinical detection based on the presence of symptoms can be very difficult. I think the next four categories are areas that hopefully future research and collaboration can really help move the field forward, and that's specifically looking at the different phases and stages of celiac disease. And I think a better understanding of early markers of celiac disease in ongoing birth cohort studies like CDGEM will hopefully help us tease this out better. And biologically, while we don't think that screening identified celiac disease is different with respect to complications, I do think that the natural history of autoimmunity could also still use some more investigation. And what I mean by this is not that we need to follow people who are not treated and see what complications they develop. What I mean is that some people screen positive for celiac disease and never actually go on to develop confirmed celiac disease. And understanding why this is will hopefully afford new screening and prevention strategies in the future. We also need to do more work around cost effectiveness of different strategies. And finally, there's ongoing collaboration to really come up with some recommendations with respect to how to manage screening identified individuals. And I will say that I put these boxes in yellow and not red because I think, we do have some data suggesting benefit in all of these areas. And I really don't think that not, meeting all of these exact criteria should preclude momentum for screening or implementation studies here in the US. So what is the status of celiac disease screening in the United States? Well, that checklist did not play out the same way for us here in the United States as it did in Italy, and due to the lack of quality evidence for benefit for identifying and treating asymptomatic celiac disease, the USPSTF states that there is insufficient evidence to support general population screening for celiac disease. But I will emphasize that insufficient evidence does not mean that it should never be done, and ongoing research, including pragmatic pilot studies, will hopefully help bridge this evidence gap. However, right now, general population screening is only offered in the US in research settings. So what have we learned from these studies? So here are some of the ongoing studies in the US for celiac screening, which will teach us more about the optimal screening strategies, treatments, and cost effectiveness. Each of these studies, the ones listed from Colorado, Washington, and North and South Dakota, take a different approach with respect to genetic or serology-based approaches. They screen at different ages, and this will give us good data to compare these different approaches. And actually, each of these studies combines testing with other autoimmune diseases. It is also important to note that with respect to the question of natural history, birth cohort studies like CDGEM will also be incredibly important. So for the next portion of this talk, I'll focus on the mass screening program here in Colorado. This slide shows our general study design. The autoimmunity screening for kids, or ASK study, screens children ages 1 to 17 years old, regardless of symptoms, for celiac antibodies. And this is offered at PCP offices, our children's hospital, and satellite locations, and actually has expanded nationally since we have at-home and lab kits. This study is also screening for early stage diabetes. And the goal of this study is to overall screen 50,000 children, and we're getting really close to that. At the time of the initial screen, we get some information from families, including demographics, family history, gluten-free diet history, and a very basic GI symptom questionnaire is collected. Children who screen positive at that initial screen are invited back 4 weeks later for a confirmation screen. And then children who screen positive on both visits are considered to have met that primary outcome of persistent celiac disease, autoimmunity, and these children are referred to GI for further workup. A secondary outcome that we're tracking is celiac disease diagnosis based either on biopsy or serologic criteria, although the formal diagnosis of celiac disease is outside of our protocol. And so here are the main findings for what was published for the first 10,000 children screened. And what we showed was that 2.4% of children initially screened had undiagnosed TGA positivity. And of those children, only 10% had a family history and only 30% had any symptoms. And so what we deduced from that is that there is a high prevalence of undiagnosed celiac disease autoimmunity in Colorado, and most of these children would not have been caught by our screening practices. So what have we learned from children diagnosed with celiac disease through the ASK study? So I should mention that we've screened a lot more since that first 10,000. We are getting closer to 50,000. And when we looked when about 40,000 children were screened, it was still about 2.1% who had confirmed TGA positivity. And there were 267 children who had previously undiagnosed celiac disease. And most of those children still do not have a family history and did not report GI symptoms at that initial visit. We also looked at the first 42 children who were diagnosed with celiac disease through our study and followed at our center. And we were able to follow them for the first year on the gluten-free diet to see if we were able to see benefit from diagnosing and treating. And what we found was that iron deficiency improves with a gluten-free diet, that many of these children had unrecognized symptoms. In fact, only 13 of these kids reported any symptoms at their initial ASK screen, and a majority of them reported symptoms at that initial visit. And 33 out of 38 of them reported symptom improvement on a gluten-free diet. So overall, these unrecognized symptoms did improve with treatment. And finally, quality of life also improved with the gluten-free diet. And during COVID, we were actually able to expand screening to adults who wanted to be screened through the ASK study. And 68 out of just over 3,000 of these participants screened positive for celiac disease. And I think what this shows us is that adults can absolutely still screen positive. So just screening in childhood is probably not going to catch everyone. It's important to emphasize that these are very preliminary results. This data actually doesn't exclude adults who already had a diagnosis of celiac disease and wanted to be screened for diabetes autoantibodies. But I think it's interesting what is shown in the forest plot on this slide is that some of the same risk factors hold in adulthood. So those who screened positive for diabetes antibodies were more likely to screen positive for celiac antibodies. Those who had a family history were more likely to screen positive. And those who were younger were more likely to screen positive. And another really important question when it comes to screening is what is the cost and what is the cost effectiveness? So it seems like from what I've shown you on previous slides that at least here in the US, diagnosis and treatment through a screening program has benefit. But how do we minimize the cost? And so that's something we actually looked at in ASK with something called a cost minimization analysis. And we compared different strategies. So we looked at a strategy that used HLA first. We looked at a strategy that used TTG IgA screening at ages 5 and 10, and then a strategy that looked at antibody testing at ages 3, 5, and 10. And we used TTG IgA testing and IgG-based testing for those who were IgA deficient. And what this study showed is that TTG IgA screening can actually be done over 5 times before it approaches the price of using HLA first. But as Dr. Catassi showed, HLA first, an HLA first strategy may be more advantageous if type A becomes cheaper. And I think another thing for us to consider is that total IgA screening actually adds 40% of the cost. So there will have to be some thought about what the best tests are if we do move to a general population approach. And then I just very briefly want to talk about combined screening. So we know that celiac disease and early stage diabetes, and that's defined by diabetes antibody screening, the 4 antibodies which are listed on this slide. We know that these autoimmune diseases have a bidirectional association. We also know that early stage diabetes screening predicts type 1 diabetes risk, and knowing that risk actually can help prevent over 90% of diabetic ketoacidosis cases. And very importantly, there are now pharmacologic and educational interventions for early stage diabetes for those who screen positive. And there are multiplexed assays that are more inexpensive that can actually screen for both things. So I think ultimately looking at different strategies for celiac disease screening, it's probably going to be more cost effective to screen for both diseases. Okay, let's switch gears and very quickly talk about the PLEDGE study, which is in North and South Dakota through Sanford Health. And it takes a similar approach to dual screening for celiac disease and diabetes as the ASK study. They do antibody screening at ages 2, 5, and 9 to 16 years of age. And what this slide shows, and what's really cool about this study, is that they've been able to integrate it into the electronic medical record and primary care visits. So patients get screened when they're already coming to their doctor. And so they've taken a very pragmatic approach to screening. And then this slide shows the results from this study so far. And what you can see is that they've had 62 new celiac disease diagnoses, which I think is pretty remarkable. And finally, I couldn't give a talk about screening for a Harvard webinar without discussing the amazing work that is being done in Massachusetts with respect to celiac disease screening. And so first I'll talk about the celiac disease genomic and environmental microbiome and metabolomic study, or CDGEM study. And this is a form of targeted screening that is led by Dr. Leonard and her team at MGH. And they're enrolling children internationally who have a parent or sibling with celiac disease and starting in pregnancy to collect data on environmental factors that can impact celiac disease development. And the study design is shown on this slide. Of the over 600 children enrolled, 77 have become positive for TTG and 45 have confirmed celiac disease. And so it will be very exciting to see how all of the sample data points that have been collected impact celiac disease development. And so that summarizes the research program, but how do we actually start implementing screening if that is the right thing to do? And as Dr. Catassi said, we have started to gather as an international community, including international experts from Italy and the Netherlands and Finland and Sweden and other locations for the Celiac Disease Screening Symposium. We will be going into our third year next year. And this is from the first Celiac Disease Screening Symposium, and some points that were brought up that we need to focus on before really there can be implementation of mass screening, or at least some things that we should be thinking about as these programs start to roll out in different countries. And those points are ensuring that there is equitable screening, that our strategies are cost effective, that we have personalization for high-risk groups, considering joint screening for autoimmune diseases, really considering what the optimal screening strategy is, making sure we have good collaboration with primary care physicians, that we have access to resources for treatment, including mental health support, dietitian support, and finally, helping to guide clinicians on how to manage the more borderline positive results. And speaking of implementation, pilot studies and pragmatic trials, Massachusetts has really been leading efforts in the United States in this respect. There is currently an act in legislature called the CAPE Act, or Celiac Awareness and Pediatric Evaluation Act. And this introduces a pilot program to screen 12-year-old children with cholesterol and lipid screening. And this will help us collect data on feasibility, outcomes, and potential long-term health and economic impacts. And all of this requires advocacy and engagement from the community, particularly so we can ensure that screening strategies are acceptable, advocacy from our politicians, and advocacy from our professional organizations. So, the AAP has this Bright Futures pathway that has been used to screen for other diseases in childhood that will likely be applicable to celiac disease in the future. And with that, we'll take any questions.
Amazing. Thanks so much, Dr. Stahl, for giving us sort of the U.S. perspective of the potential for mass screening for celiac disease, and also just giving some folks here who are from Massachusetts some relevant things that's on the legislature sort of table to sort of discuss in terms of screening our children potentially in the future. I'm going to switch over now to the Q&A session. As I'm sort of looking through some of the submitted questions here, I'm going to sort of peruse some of the pre-submitted questions. And again, thank you both, Dr. Stahl and Dr. Catassi, for a lot of very helpful information, but also hopefully laying the groundwork for something that we may potentially see in the future, as, again, a lot of folks have celiac disease or may develop celiac disease, and we just don't know yet. So hopefully we'll be able to uncover more of the iceberg in the future. I guess the first question I have here is I'm going to ask Dr. Catassi, and certainly Dr. Stahl, feel free to share your thoughts as well. But in terms of implementing screening in Italy, one of the things that from a clinician standpoint I think about is, what are people going to think about screening positive? And our concern is always, before they have a formal diagnosis, if people start looking online or going through different groups and find out, hey, if you screen positive, you may have celiac disease, they may start a gluten-free diet before having a confirmed diagnosis. In sort of this sort of process and getting mass screening done in Italy, is there some work being done in terms of educating those who are being screened, but also clinicians who might be interested in enrolling their patients or people that they know into this sort of mass screening protocol on how to sort of go about in responding to a positive screen?
I completely agree with you. A program of mass screening should go together with a lot of information given to the general population, to the family pediatricians, to the lab people. And this is what we start to do now. We give, we did an education campaign before starting the pilot project in the way that every participant knows what is the aim of the screening, what are the pros and cons and everything. And my experience is that people is very happy to do the screening for celiac disease. We found very high acceptance. And as Marisa said, there is some sort of complementation between the screening for celiac disease and type 1 diabetes, because in my experience, people is more prone to do the screening for celiac disease because they know that it's something that can be approached from a therapeutic point of view, while there is some resistance against type 1 diabetes screening. So the idea of combining the two screening, I think, is very, very good. Another big discussion here is who should do the first screening test. We believe that the family pediatrician is the person who should inform the family and who should perform the test. But this is more costly than other ways of doing this program. For example, you can do the screening in vaccine centers. This is less expensive, so you have to find a compromise. But I hope in the end the screening will be done by the family pediatrician because this is the right place to do this procedure, and it is the person that can inform the family before, during, and after. There is the problem you said of the gluten-free diet, but in children it's not quite common to find children who are on a gluten-free diet before testing for celiac disease. So it's not a big problem right now.
Awesome. Thanks so much, Dr. Catassi.
I can kind of chime in a little bit on the landscape here in the United States because I think it's a little bit different. I think we probably have more kids who are already gluten-free, or I think your question was, and something we're tracking in the ASK study, but I didn't show a slide on, is like how many people get that positive result and just go gluten-free on their own and never come and see GI. Because I think that is a potential disadvantage of screening. But I think, as Dr. Catassi was saying, for effective screening, we really need good collaboration with primary care providers. And we will definitely need to emphasize that insight of like a positive result does not mean that you have celiac disease. There is more testing to be done here, and you should not make any dietary changes because it's a lifelong commitment to a diet that you may not need. And so I think that is a really important point. I also just want to say, because there was a question in the Q&A about diabetes screening, and we were talking about diabetes screening. So the antibodies that I flashed up are islet autoantibodies. That's IAA, GATA, IA2A, and then zinc or ZNT8A. And these are all just different islet autoantibodies that signal early stage diabetes. And when you are positive for multiple of these antibodies, the risk of diabetes is much higher.
Awesome. Thank you so much. And maybe along these lines, I think a question that came into the Q&A during the talk was, can you, just for our viewers, can you share a couple of examples of what could cause a positive TTG that's not due to celiac disease? And this is open for either of the speakers.
This is like just a day in clinic for us, right, Dennis? So one scenario that we very commonly see is kids have like a gastroenteritis or a stomach bug, they go into their PCP, they have more of these acute symptoms and they get screened for celiac disease and a low positive. Well, infection can cause a low positive TTG result. Anything that causes inflammation can also cause a positive TTG result. And going back to infections, so there are stomach bugs, but then another really common scenario is H. pylori that can also cause a positive TTG. And then finally, sometimes having other autoimmune diseases, your body is just kind of on overdrive producing all these antibodies, and you can get false positive TTG results. And then sometimes kids are just positive, and we don't know exactly why, but that antibody goes away over time, something called transient positivity. So once again, I do think it's important to emphasize that a positive test alone does not mean celiac disease.
If I can add a few words, I completely agree with Marisa. And another problem that we can have sometimes is that the value of the TTG antibody may depend a little bit from the technique of measurement of the antibodies. For example, there are methods using the ELISA technique that are more conservative and more specific, but may be a little bit less sensitive, while chemiluminescence is in the opposite way, a little bit more sensitive, but sometimes you can have some false positive results. So it is a very important choice, the technique of determination of the antibodies in the screening. We are still discussing about that in the Italian program.
Excellent. And just to sort of echo on that last point, and then I'll ask another question to the group here. But even in the US, we know that there's several different types of assays and ways to measure TTG. And in my clinical practice, but also when we've studied it, there definitely can be variations from one test being positive and another test to be negative. And so which one's correct? And so just to echo the point that a positive screen doesn't mean you have a condition. It's sort of just like how the algorithm Dr. Catassi and Dr. Stahl have shared. It's sort of a part of the step to sort of that requires further ongoing workup and evaluation. Another question that sort of came up in one of the pre-submitted questions was, we know that a lot of the topics here were around pediatric screening, but we also know that a lot of viewers could be adults. And also, Dr. Stahl, you shared some data about in adults, and they asked that they also screen positive. Are there any discussions, or do you foresee a potential mass screening algorithm for those who are adults?
Marisa?
I can go first, yeah. So I think, what we have seen in birth cohort studies is that the incidence of new cases is certainly higher in pediatrics. So I think the efforts right now are really focused on the pediatric population and childhood screening. But with that said, you can develop celiac disease at any point throughout the lifespan. And so I think it's important to think about, screening in adults as well. And I think that comes down when we're talking about mass screening to cost effectiveness and ultimately looking at what is the cost and what are the benefits that we're getting from screening in adulthood. I think this needs to be separated, though, from who should be able to be tested if they want to be tested, right? And so as an adult, if you're feeling like you have any of these symptoms or signs of celiac disease or these conditions that increase your risk, you should certainly go to your doctor and ask to be tested. And that's kind of outside of a broader screening algorithm.
I'm strongly in favor of pediatric screening, of course, because if you look at the preventive effect, this is much higher in children than in adults, because we know that some complication of untreated celiac disease may develop slowly, for example, osteopenia, sometimes infertility, and therefore making a screening in adults still makes sense, but the potential for prevention is much lower. Therefore, the efficacy of the screening is much higher if we think of this strategy in children, in my view.
Excellent. Thank you very much to both of you guys. Um, One question that also came up was, and I think, Dr. Stahl, you shared some information about compelling information of why it is that even if you feel like you don't have symptoms, it would be helpful to know if you have celiac disease and even treat it because you may have symptoms that you don't quite recognize yet. But there was one question that was shared by a viewer that asked if I have celiac disease, but my partner and my children are just not interested in knowing about whether or not they have celiac disease, what is it that I can share with them, or what is it that I can, do to help advocate for considering screening?
Yeah, so I think this all ultimately comes down to personal preference. And there are some people who like to know their status, and there are some people who probably prefer to just not know and ignore things. But if they're going to not know and ignore things, I think they need to know that they may have unrecognized symptoms that will get better when they go gluten free. Um, that untreated celiac disease has been tied to complications later in life, as Dr. Catassi was saying, osteopenia and bone disease, infertility in women, and then the feared complication, although very, very rare, of very rare GI intestinal cancers later in life. And then in children, one thing I'm always worrying about is there is a very limited window of intervention with a gluten-free diet to help with growth and development. And so, especially for children that are at higher risk, are we missing that opportunity or window if we just ignore it? And so I think it's important that they know and are aware of these things, as well as, other things like iron deficiency, which maybe you may not have a ton of symptoms of, but you do feel better after you get treated. And then quality of life. And I think part of that, improvement in quality of life is that there were things that you didn't recognize before you went gluten free, and then you start to feel better being gluten free. So I think those are all things to share with family members who don't want to get screened, but at the end of the day, that is no preference.
Excellent. I think we're sort of near the end of time, but I just want to summarize by thanking you both for really sharing, compelling data, and also again, Dr. Catassi for sharing with us how it is that Italy became really the first place to implement mass screening for, both celiac disease and type 1 diabetes. So look forward to what you guys learn and can share with the rest of the world. And I thank everyone for joining. I'm going to switch it over to Chris Rich to wrap us up here today.
Well, thank you, Dr. Chang, and thank you to all of our presenters and attendees for your participation today. We hope that all in attendance found this webinar educational and helpful. Please note that if you registered for continuing education units by following the instructions that were presented to you in the chat box, those units should be received in the next 2 to 3 business days. Also, please remember that the recording of this and all past webinars in the All Things Celiac series can be found at nationalceliac.org. We encourage you to keep an eye on the Harvard Medical School and National Celiac Association websites and social media accounts for updates and additional information about the timing of future All Things Celiac webinars. So on behalf of all of our esteemed guests and from all of us here, we look forward to seeing you next time, and thank you for your continued support.